Yes, there it goes. Yay! It worked this time. Okay. Hi, everybody. So, we had some technical difficulties tonight, but that's okay. We are here. I'll wait for you guys to get in the room. I'm really, really excited. I don't know. I don't even know if excited is the right word to use, because like what we're going to talk about tonight isn't necessarily things that make me happy or, hey, Almighty, how are you, honey? But, with all the changes, hey, Teresa, hey, Mookie, with all the changes that we've had in our healthcare system, we haven't had the opportunity to have we haven't had the time to, or the opportunity to have someone who's worked in the environment. Hey, everybody. We had technical difficulties. Sorry about that. But to have someone have the freedom to be able to speak and be willing to speak on camera and on the issues. So I'm really excited about having this opportunity because you're not going to just hear from Dani, right? You get to hear from someone who's been on the front lines in the midst of this thing prior to the merger, during the merger, and after the merger. So I'm excited. And having said all of that, here's what I want you all to try to do is I will take questions throughout this process. Hey, Wanda. Hey, everybody. But just be patient. Give us time to answer them. I'll pop your question up so that it can be addressed at that time. And then we will be able to go from there. So having said that, I'm going to bring on my guest with us. So she is a phenomenal individual, someone that I have grown to respect and love throughout the last 18 months or so. So this is Alicia Gaddy. I'm going to let her kind of give you a little bit of background so that you can know her professional background, and her areas of expertise. And I will let her tell you a little bit about herself and then why she decided to do this interview. So Alicia, welcome. And thank you for coming. Oh shit. Wait. Now say it.
You're very, very welcome. It's good to be here.
Good. I am so glad that you're here. So, Alicia, what is your area of expertise in the healthcare field?
Let's see. Well, I graduated ETSU in 1995, where I got my registered nurse. And then I went back to Neonatal Nurse Practitioner School and graduated that in 2005. I got my master's at the Medical University of South Carolina in Charleston.
Okay, awesome. So neonatal nurse practitioner, which means you work in NICUs, so neonatal intensive care units, primarily?
Correct.
Okay. And so so in this region, we know that you no longer work in this region, but in this region, can you tell us who you were employed by and what position you held and what hospitals you worked at?
Sure. So I want to start, because this is laying heavy on my heart first, because there will be people that will see this live. I know, as you know, that let's get this off my chest first, because I know that there was some people angry with you for revealing the truths. And I want to speak to the staff that are going to see this, that they all know that I think they're amazing. And this isn't about the staff at all. This is about you and how you're treated and what upper management and your politicians did to you. So there, we can get that out of the way.
Awesome.
So go ahead and ask your question again, because I wanted to get that off my chest.
I got it. Yeah. So again, it's something that, and I appreciate you clarifying that, because I think sometimes staff has felt like when we've talked about the truth and we've talked about the things that have happened, that it's been an attack on staff, and it's not. What's happened has been a result of choices and changes that the administration has made. and things that the
Correct.
politicians created. And so, yeah, you know, I'm so glad you pointed that out. So yes, staff, it is not about staff. It's about the environment that's been created by the administration and by the politicians in the state of Tennessee. So, so you, when you worked in the healthcare system here, who were you employed by?
I did my clinicals at Johnson City Medical Center in their NICU because my master's program was online, and actually started working with ETSU Physicians in April of 2006 as a
Okay.
neonatal nurse practitioner.
Okay. So working for ETSU Physicians, also known as MEAC,
Correct.
and as a neonatal nurse practitioner working in Niswonger's NICU at Johnson City Medical Center.
Yes, of course. And when I started, Niswongers didn't exist. It
Right.
was Johnson City. Yeah. Mm-hmm.
Yeah, it was Johnson City Medical Center's NICU, Neonatal Intensive Care Unit. For those of you guys who don't know, the Neonatal Intensive Care Unit is where our our newborn babies go that aren't well enough. Uh-oh, we just lost Alicia. She'll be back. She'll join back. It's where the neonatal intensive care babies go when they are not well enough to go to the well baby nursery. So hold on a second. Sorry, guys. Technology. Hold on. We lost her, so give her a second to come back. Well, let's see what happens. Sorry, technology. I don't know. I'm trying to see if I can get her back. Give me a second. Sorry. Can you guys still hear and see me? Let's see. I'm assuming that you guys can still see and hear me. Because she is the center of the interview, right? So I need to get her back. It is possible because she was on her phone. It is possible that her phone died. Okay, I'm glad that you guys can still see and hear me. Great. No, I don't think so. Yay, everybody is still here. I'm great that you guys can still hear and see me. Shit. Let me see what's up because okay. I can't see or hear you. It's like you're gone. Well, we can't see or hear you. Yeah, so you might want to close it out and rejoin again. Like close it. I'm going to hang up, but close out and rejoin. Okay, bye. So she said she could see and hear. She said she could hear me just fine. So here, let me just say this. If this happens again and I lose her, I will shut down this broadcasting software. She and I will go straight Facebook to Facebook, and then we'll broadcast that way. This will happen tonight. Yay, she's back. Yep, you're with me.
Okay. It was
all right. She's back.
This is my tablet.
Yes. Perfect. Okay. So, and this is what I told them. If we lose you again, it doesn't matter. We'll figure it out. And if we have to, we'll shut this sucker down and we'll do it on the Facebook platform. Facebook changed its broadcasting platform, and sometimes it's caused integration issues. But okay, so here's what we were saying: is you were saying that you did your clinicals, you had been at the NICU at Johnson City Medical Center since 2006.
Correct.
So I know that there are hesitations about coming on and talking about those things. Will you share just briefly why you were willing to come on and do this interview?
Because of, I guess, just the changes that happen. And I know that sometimes change is good, but if you're going to change, you have to prepare for that change before it happens and not just change and go, okay, we'll figure it out as we go. No, that don't work, especially when you're talking about babies.
Gotcha. So having said that, one of the changes that happened fairly quickly was a change in the director of neonatology back in the fall of 2018. Can you talk a little bit about that and how that change came about and what your thoughts are around that?
So, we had a director retire, and then the new director that was chosen, he went through all the appropriate channels, applications, he was hired. He was, and then all of a sudden, everyone gets an email saying that he had been removed from his director position. He still worked as a neonatologist, and bing, bang, boom, another one had just been selected.
Okay.
From the group.
So my understanding is that, so what we're talking about now is that in the fall of 2018, Ballad Health had a plan that they were going to close the Holston Valley Medical Center NICU. And the current director of neonatology at Johnson City Medical Center's NICU, my understanding is that he didn't agree with that plan. Is that right?
Correct. The director that was chosen in 2018, after the one retired, he did not agree with that plan. And in fact,
what was the plan that he wanted?
He envisioned keeping Holston Valley a level 2, hiring more staff, having a neonatal nurse practitioner there 24/7, and having more staff to staff this level 2 nursery.
Okay. So it's important for everybody to understand that Holston Valley Medical Center's neonatologists were employed by MEDNAX, right? So we had a MEDNAX contract that supplied Dr. Powers, Dr. Tanvir, Dr. Martin, and then the neonatologists at Johnson City Medical Center's NICU were employed with a contract with ETSU Physicians / MEAC. So Ballad has told the director of neonatology in 2018, in the fall of 2018, listen, our plan is to close Holston Valley Medical Center's NICU from the level 3 high level that it is now down to a well baby nursery. And this director of neonatology at that time did not agree with that decision. He wanted to keep Holston Valley Medical Center a level 2 NICU and hire more ETSU physicians, neonatal nurse practitioners, and neonatologists to staff and provide coverage so that the babies would be taken care of at both hospitals. What do you think? What do you know of? What are you aware of as his reasoning for not supporting the closure of the NICU at Holston Valley and believing that it should stay at least a level 2?
I think this is just my personal opinion, that he envisioned what could happen if you didn't have a level 2, and that is every baby being transferred to one center. And I think plus 2, he also liked the fact that the less that you can separate moms and babies, the better off babies are, and the better off mothers are. I
Mm-hmm.
definitely don't think he saw it as a dollar sign opportunity at all, because he knew it cost money to run it. I just think that he envisioned um, being able to take a load, like, because now that Niswonger is the only level 3 NICU, it can get overloaded, and there's no place to take the extra volume to. I mean, there's a chance that the place could actually, I'm going to use the word implode, because that is explode from within. And I think he envisioned that.
So you mentioned there could be problems with an overflow of babies and the number of babies. And one of the things that we talked about when Commissioner Dreisner had asked Ballad to provide additional information about the numbers of babies that had been at Holston Valley's NICU, at Johnson City Medical Center's NICU, the age of gestation of those babies. Ballad Health maintained that the majority of the babies that were 35 weeks and above in gestation would be able to stay at the hospitals where they were born. They would not need to be transported to Johnson City Medical Center. And in the documentation that they sent to the Department of Health, it actually showed that out of the approximately 300 babies at Holston Valley Medical Center's NICU, 186 of those babies were over 35 weeks in gestation, right? So there was a concern that Ballad wasn't including those babies in those numbers, and that Niswonger's NICU at Johnson City Medical Center would exceed its capacity. So to your knowledge, I know that they are licensed for 38, 39 babies. To your knowledge, has Johnson City Medical Center's NICU exceeded their capacity? And if so, what's the greatest number of babies you've heard of at that facility since the merger and the closure of Holston Valley's NICU?
Between 52 and 54 at one given time.
52 and between 52 and 54 babies at the NICU at Johnson City Medical Center, and they are licensed for somewhere around 38, 39.
Correct.
So I want to be clear with individuals. How many neonatologists are on staff at Johnson City Medical Center's NICU at one time?
There is one neonatologist. He's called Neo 1, and there's Neo 2. Neo 1 is responsible for the main side of the NICU, and then it just started before I left, that Neo 2 would go over to what's called the 3400 hallway, and that's the rooms that actually babies can room in with moms. So she was responsible for those babies. So yeah, so even if there was say 20 babies, it still had 32 babies for the neonatologist, the nurse practitioner, and the residents to be responsible for on the other side.
So you're talking at least 30 babies for one neonatologist on the other side.
At least
30. Okay. Now,
and on the weekends, there was that whoever was seeing those 3,400 hallway babies, let's say, I'm just going to use the number 20. Let's say there was 20 over there. Now on the weekends, they didn't see them. So now you're responsible for that one neonatologist is now responsible, and the nurse practitioner is responsible for all 52 babies.
Wow. So I have talked to, as you know, a lot of neonatal and perinatal experts. And I have been told that in some of the best NICU programs, the maximum number of babies per neonatologist is 20 to 23. Does that sound about right to you?
I can tell you it's right, because I've done locum work in several NICUs. I've been in Memphis, I've been in Knoxville, I've been in Baltimore, and usually, not usually, always there was these big units were divided up in teams. You had a Neo and an NMP on each team, and there was usually between 20 and 25 babies per team.
So between 20 to 25 babies per team. And what we're hearing is that in the best of circumstances at Johnson City Medical Center at Ballad's NICU there, when they have 52 to 54 babies, in the best of circumstances during the week, one Neo is going to have at least 30 babies.
Yes.
So can you share with me what are some of the issues that can arise when you have that many babies and you have a shortage of staff, or you have an abundance of traveling staff, and then you have transport issues? Can you share with me what are some of the things that can happen?
You hope not. I mean, you hope that you covered everything, but you're just like anything else. You're just more prone to mistakes. Things get chaotic. Orders aren't written. And you go backtracking, and then people asking, "Oh, did you want this? Did you want labs?" It's just easier to make mistakes.
And you had mentioned that the director of neonatology that was abruptly removed, who did not agree with the closure of Houston Valley Medical Center's NICU, he envisioned some of these potential problems, right?
He must have. I mean, he definitely must have. He didn't. I mean, I didn't hear discussions as far as to, but obviously he had to.
So now the neonatologists that are on staff, do they stay in the hospital 24/7?
No.
So when they leave, around what time of day do the neonatologists leave?
It varied from day to day, but usually by 4:30 or 5 o'clock.
Okay. And so what time would they come back?
8 a.m.
So from
give or
give or take. So from 4:35 p.m. until 8 a.m., who's taking care of these 40, 50 babies?
One neonatal nurse practitioner.
One neonatal nurse practitioner. Mm-hmm. Okay. Okay. So right now there is a federal antitrust lawsuit that's in the appeals court between Ballad Health and ETSU Physicians / MEAC over what's called an interlocking directorate issue. So we have 3 members of the Ballad Health Board of Directors that are also 3 members of the ETSU Board of Directors, which oversees ETSU Physicians and MEAC. Okay. Ballad has maintained, and ETSU has maintained, that there is no conflict of interest between these two. In your opinion, have you ever witnessed or seen circumstances where people have been either removed from positions or
reprimanded? Yes.
Yeah.
Yes.
Okay.
I can just during the onboarding of telemedicine, one of the neonatologists was threatened with removal, being fired, just not renewing his privileges when they came due. And one of the neonatal nurse practitioners was told that if she did not file her credentialing paperwork, that she would get a written letter of warning put in her file.
So what I'm hearing you say, correct me if I'm wrong, is that when Houston Valley Medical Center's NICU was going to be closed and they were going to institute this, telemedicine was going to be used in its place, that the same neonatologist who used to be the director, who had been removed from his position, also did not want to get privileges at Holston Valley over concerns with the
Yeah,
telemedicine.
sure. Over legal
Okay.
concerns. He had a lot of
Over legal.
concerns. Hmm.
So when you say legal concerns, can you let people know what that means?
Well, telemedicine for all of us, I mean, was a whole new ball game. We didn't know where we stood with our malpractice insurance and what kind of legalities could arise when you're
Okay.
just on a computer telling other people what to do. So, he was very concerned about that. And you also raise concerns. It's natural. You raise concerns when you're on a telemedicine call with people that you're unfamiliar with. You do not know their skill level whatsoever. You know, trust is developed over time.
Mhm.
So that was a big issue too.
Got it. So there were concerns over, the safety aspect, the ability to make this flow cohesively, and because of that, he did not want to get privileges, and was told as a result, if you don't get these privileges, then when your contract is up, it will not be renewed. In other words, you're going
Correct.
to be out of a job.
Correct.
Got it. So it would appear that Ballad Health's desire to close that NICU and to have it staffed via telemedicine in impacted ETSU's willingness to employ this provider. Does that sound about accurate?
Well, I mean, of course. And you have to, if you go back and look at the COPA, the letters back and forth to Commissioner Dreisner, to the Ballad Health leadership. I mean, telemedicine was in their agreements. It was never in ETSU's agreements. ETSU wasn't writing Commissioner Dreisner.
Right. Right. So if telemedicine became a focus, it was a Ballad Health focus. It was a Ballad Health initiative.
Mm-hmm.
And if an ETSU employee did not want to do telemedicine, the only way that would be an issue is if it was an issue for Ballad Health. So
Correct.
it appears that Ballad Health is able to use their influence to affect ETSU's employees, even though ETSU Physicians is supposed to be a competitor of Ballad Health.
Yes, that is my opinion. Yes.
Got it. And it sounds to me, I'm no attorney, but it sounds to me like that's exactly what this federal lawsuit contends. So what I'm hearing is federal antitrust issues from an interlocking directorate perspective. I'm hearing safety concerns, decreases in quality care, and the ability for providers to ensure the health and well-being, doing the best that they can with the numbers that they have, right? We're in no way knocking staff. Like you said at the beginning of this interview, this is not about staff. Staff is doing the best they can, right? They're just in an impossible situation.
They are. And I have had, like you, I would never betray the people that are close to me, the people that tell me I would never betray them. But, it's really sad, the people that have actually come to me and said, I wish we could speak out. We don't like the way things are being done, but they can't. They can't.
So, have you seen any other instances where staff had concerns about the changes that were being made and they opposed those changes, and Ballad Health leadership issued warnings or threatened their jobs?
I can't personally pick one out in particular, but just the fear that people have, they all fear it. They all fear it.
Has there ever been a time that you know of that you have experienced working at Johnson City Medical Center where, you all's jobs positions have been threatened and been told we'll get rid of you and hire someone else?
Yes. So this happened. This was, I guess, pre-merger when they were, pre-merger, just picking contracts, doing this, doing that. And the upper management for Niswonger Children's Hospital threatened the whole ETSU neonatal staff that they would just fire us all. In other words, well, I'll just get rid of the ETSU contract and I'll bring Mednex in and get rid of all of you.
What was the reason for that threat being made?
I wasn't at the meeting, so I can't speak to that, but I just imagine if I'm not going to get my way, then I'll find somebody that will give me my way.
So, and that's another example of Ballad Health being able to dictate what ETSU physicians employees did or didn't agree to in terms of, managing those facilities. Okay, so just a little bit more. So at night, we've already talked about the fact that in the evenings, the neonatologist isn't there. They normally leave around 4:30, 5 o'clock in the evening. They come back around 8 o'clock in the morning. And the only person there that's not just an RN or support staff, and I don't mean that when I say not just, we know that the RNs are amazing. We all know that I have a tremendous amount of love for my NICU nurses, so don't take that as a diss at all. But in terms of, yes. But so in the evenings, when there's no neonatologist on staff, there is a neonatal nurse practitioner. About how many NICU nurses are on staff at night at Johnson City Medical Center?
Oh, that varies so vastly from I guess the amount of babies, but I'm going to say on average 10 to 15 on average.
10 to 15. So if you have 10 to 15 nurses there and you have 50 babies, you're still talking 3 to 4 babies a piece, right? If you have less than that, that's at 15, right?
Yes.
3 babies, 15 is 45, right?
Yeah. 4 baby assignments. That was other than their critical babies, babies on ventilators. Like you could have two vented babies or 2 CPAP babies, or a baby on a ventilator and a CPAP baby, or a ventilator baby and a feeder grower. But if you had a ventilator baby, you was only supposed to have 2 babies.
So in your experience there, how common was it to see higher acuity babies with nurses that had a higher than normal for standard of care nurse to baby ratio?
If transport had to go out, it occurred frequently.
Okay, so talk a little bit about that. What are some of the challenges, especially at night, that can come up with regard to transport and nursing and staffing?
Well, there and then not just nights. Sometimes days you would have your charge nurse have an assignment and also be your transport nurse. So if your transport had to go out for any length of time, you lost your charge nurse. Let's say your charge nurse is taking care of 2 babies. Now somebody has to take her assignment and play charge. So, and plus now you're the only you're the only NICU. If there's a transport, you're going to get it. So obviously transport is picked up. So yes, there were times that, or if the transport nurse had, let's say the transport nurse had a 3 baby assignment, then now somebody has to split those and take her assignment while she's out.
Got it. So
if we go to Harlan, Kentucky, it's going to be several hours.
Right. And even sometimes, depending upon where in Southwest Virginia, it's going to be, yeah, absolutely.
Several hours.
So what I'm hearing is when you have a charge nurse, ideally speaking, you would want the charge nurse to not have a baby assignment so that they can oversee the floor. But in many cases,
only that, the charge nurse, not only does she have her charge responsibilities at, staffing and that, but she could also help relieve nurses for lunch. She could help start IVs. I mean, just any little things that come up, she can help. But with an assignment that made it hard.
Right. So if that charge nurse has a baby assignment of her own, and she has 3 or 4 babies that she's assigned to on top of her other charge nurse duties, and she's the transport nurse as well, then you have a conundrum where if a baby has to be transported, one of the other nurses or the other nurses have to then take that assignment. They have to divvy those babies up. So if you already have 4 babies, you might have 5 or 6 babies while that charge nurse is out on transport. And depending upon where that is, that transport may be several hours. And even in best case scenarios, even if you're going 35, 40 minutes from Johnson City Medical Center to Indian Path or Holston Valley, you still have to get the babies and all of that and then come back. You're still talking on average, what, 90 minutes?
And on top of that, the charge nurse was the nurse that went down on any critical deliveries. So not only did you lose, not only was she your charge nurse, she had an assignment. Let's say you had a 24-week delivery. She was also the one responsible, her RT and the nurse practitioner, for going down on that delivery. So now you lost that too.
So lots of room, like it's literally a crapshoot, praying that all of these things don't happen at the same time, that we don't have the perfect storm. Because if we do, holy crap.
Correct.
So I want to ask you about something that I know you weren't there for, but you talk to people who were similar to like I did. And just for, just to back me up, that's your little puppy you got, I know. But just because it was said that it wasn't true. So I had reported that when the telemedicine was brought over to Holston Valley Medical Center, that it was a week before Holston Valley's NICU was scheduled to close and did in fact close. And they had just started 5 days before closure training the NICU nurses there. Is that an accurate statement?
Yes.
Is it an accurate statement that, God, I love you so much right now because I caught so much shit.
I'm gonna put you on. I'm gonna tell you to hold on a second. Hold on 1 second.
Okay, honey.
Hey Ray, will you take Kimber out? Take Kimber out. He's wanting to go out.
Take the puppy out.
Yeah. My husband's coming to take him out. Okay, go ahead.
And so in September, after the telemedicine equipment was active at Holston Valley Medical Center and Indian Path, are you aware of a time where there was an emergent delivery that took place? A baby was not doing well, was in distress. Telemedicine equipment was attempted to be used and wasn't working properly. And nurses had to use a cell phone to FaceTime Neonatology at Johnson City Medical Center to work through that issue. Are you aware of that happening?
It did happen.
It did happen. Thank you. When we talk about all of the concerns that are happening, share with me and the public, where do you work now? You don't have to say just the state.
I work in Georgia.
You work in Georgia. And how many days a month are you gone from your family?
10 days a month.
What made you finally decide to quit here and take that on and be away from your husband and away from your family, for that length of time?
I put a post about it, and my decision was twofold. My first decision being that as I got older, the level 3 NICU got harder, and our volumes increased more. But the main reason that I had was I could not sit back anymore and watch and hear the things that I would hear, and watch the nurses that I loved dearly be just treated the way they were treated by upper management. I was too heartfelt, and I couldn't do it. I could not do it. I couldn't. I stood up against telemedicine in the way it was presented. And I know for a fact, I knew many of the nurses at Holston Valley, and I know they were great nurses, but they were instantly put in positions to say that they could do procedures such as intubations that they had never done before. And I could not support this at all. Every intubation that I did, every intubation that I learned with, I had a neonatologist or a nurse practitioner standing over my side, right behind me. And I just know that, the dangers. I just know the dangers. And I also know of many babies that I've resuscitated in the delivery room. Sometimes positive pressure ventilation can get you out of a horrible mess, whereas intubation can make a baby worse, because every time you put the laryngoscope blade in the mouth, you can vagal the heart rate, and therefore you're making things worse and worse. And I just couldn't support it. I could not support it.
I want to make sure that we've touched on all of the issues that we wanted to touch on. In all the time that you've seen this merger happen and everything that's changed, what is your opinion about the environment that Ballad Health's management and administration has created for staff? What do you feel that environment is for them?
It's a very hostile work environment. People come in and they do their jobs to the best of their ability, but it is hostile. You can tell it's hostile. People will huff and complain, to each other. It's just different. It's different. It's a different place than what it used to be. I have truly had people tell me, now this is after they built the Niswonger Children's Hospital, okay? There was many of us that stood in front of that opening, that grand opening, and were so proud of this new hospital. I have had since then people tell me, I used to be proud to tell people where I worked, and now I am not.
I got that. Golly. So in your opinion, have you seen instances where you felt like babies at the NICU could have potentially gotten better faster or not developed other issues had the staffing issues and the volume issues all be present and Holston Valley be closed?
It is my opinion that discharges were, the length of stay was longer because you had more 4-baby assignments and less time. So it is my opinion that length of stay, and it will be longer. And just a little bit, just as just a side note of of what I'm doing now, because I'm actually working in a level 2 NICU now. And this level 2 NICU is closely controlled. Number one, the state of Georgia, they actually have laws for level 3, level 2 NICUs. But part of the annual review comes from not only the state, but also one of the neonatologists that are in the nearest level 3 NICU. And I happened to be there the day of the review, and I was talking to their neonatologist and probably the director. I don't know. He was a very nice gentleman. And I said, I just told him, I said, I'm proud to support a level 2 NICU. I said, because I don't think there in your level 3 that you want all the transient tachypnias, that are going to get better in 48 to 72 hours and go home. I don't think that you all want all the hypoglycemic babies that might need a UVC to run a little extra percentage of glucose because, because the well baby can't have, a UVC. It's like that keeps pressure off of your level 3 NICU. And he agreed with me.
So if Ballad Health had kept Holston Valley Medical Center even a level 2, it would have allowed for lower acuity babies to remain at Holston Valley Medical Center, Johnson City to not have the high volumes that they currently have, which would have made staff less stressed, lower baby assignments, and probably shorter length of stays, indicating babies got better sooner. Because when you have we all moms know this, right? If I have 4 babies at home, it's harder to give 4 babies the individualized care that they need. Whereas if I only have 1 or 2 babies, right? That's
Right.
true for moms, and it's true for NICU nurses.
And then plus even the providers would be able to give, let me go back. You talked about, I remember in one of your lives talking about, volumes and improve outcome. Volumes are only going to improve outcomes if those volumes are the type of volumes that are rare volumes. So in other words, a transient tachypnea of the newborn, it's going to get better. It doesn't matter if you see 2 of them or 400 of them. It's transient tachypnea in the newborn. But if you start saving micropreemies, if you start saving 23 weekers, then by keeping your babies that are going to get better in 48 hours to a week, maybe even 2 weeks, out of a level 3 NICU to where they can concentrate now on the micropreemies, man, they're going to get really good at it.
Right. So what you're referring to is when Ballad Health first started talking about closing Holston Valley NICU, they said that Johnson City Medical Center and Holston Valley both weren't staying at a high volume in terms of their capacity. So they weren't staying 70%, 80% full. They were both staying about 50-50, something like that. And Alan Levine kept saying to people, the American Academy of Pediatrics says that when you have higher volumes, it produces better outcomes. And that's true. But there's 2 pieces to that. One is what you just said, is that if I stub my toe, it doesn't matter if the doctor sees me for my stubbed toe, the toe is going to get better regardless, right? So there's nothing that I need to do something amazing about that, right? But if I have a daggone brain bleed, right? That's a different thing. The more brain bleeds that neurosurgeon sees, that's a very specific, a very specialized thing. Then yes, volume will produce higher outcomes. So
Yes.
when we're talking about when people think NICUs, they tend to think that they're all micro preemies like Bella is. But the truth is, the majority of them aren't micro preemies. I think micro preemies only account for what, 12% of all NICU babies, give or take?
And that I would say that's correct. I mean, I would have to go back and actually look, but that's probably correct.
And then
The majority of,
the
oh
other
yes,
part
is
I
your,
was reading from the American Academy of Pediatrics journal is it also says that volume accounts for a 9% increase in outcomes, but the other increase in outcomes were other hospital characteristics, it says. Things like the relationship that you develop with the staff, the comfort level that staff has with their providers, the type of equipment that you have, your assignment ratios, all of those things are secondary indicators of outcomes. It was touted by Ballad Health and specifically Lisa Carter and Alan Levine that volumes were the sole indicator of outcomes, when in reality, that's only 9%. And there are so many other things that also affect outcomes.
very true. Very
And
true.
this is a great statement right here. So Mike DeVoe says higher volumes require improved RN staff and MD staffing to do it safely. So if you increase those volumes, but you don't have the staff to support those volumes, then those higher volumes can, in fact, instead of producing better outcomes, can produce
They're going to
negative,
produce worse.
worse
It,
outcomes.
anytime, I don't care what interest, I don't care what industry you are in. I don't care if it's a NICU. I don't care if it's producing Hallmark cards. Okay. If my volume, if if I don't have enough employees and my volume increases, and I don't produce quality staff, quality everything, my total quality is going to decline. It cannot help
Mhm.
it. I don't care if if I am giving 120% of myself, I cannot keep up. And that's with anything.
Yeah, agreed. We've talked a lot about the struggles that staff has faced with this merger and with these changes, and the relationship between ETSU Ballad Health and the issues that it has caused for staff and baby assignments. Can you speak to briefly what, if any, challenges you have seen for the families of these babies with these changes? Ballad had proposed they were going to have gas cards for parents. They were going to be able to, put everybody in the Ronald McDonald House and all of those types of things. What kind of challenges have you seen for families now that all of these babies have to be, transported and treated at Johnson City Medical Center?
Well, number one, there's only one Ronald McDonald House. I'm not even sure how many rooms that it had, but I do know, even like, let's say the NICU, let's say we only had 20, 25 babies, there would be times the Ronald McDonald House would be full, because the Ronald McDonald House is for all of Children's Hospital. It's not just NICU staff that's utilizing it. It's PICU staff, mothers, fathers, and it's also, pediatrics.
Mm-hmm.
So, to say that they could use Ronald McDonald House, that don't, it's a great place. Um, plus two, the Ronald McDonald House, um, their, I guess, laws, bylaws, whatever you want to call them, they were pretty strict too. So that could affect the ability of some families. But I personally, if there were gas cards given out, I never saw them. So I cannot speak to that. I never saw them, but I said on more than one, meetings and stuff, that the families specifically spoke to having travel problems. You know, not everybody has 3 vehicles sitting in their driveway.
Hmm.
We forget that. Um, and for anyone to say that it's just 30 miles, it's just 30 miles. Well, it's not just 30 miles from Big Stone Gap, Virginia. It's not just 30 miles from Rogersville. It's not just 30 miles from Mount Carmel. Um, and, people forget this area is, there's a lot of challenges in this area for people. There could be jobs, but some of them are low paying and people do the best they can.
Yeah.
And
So,
I heard parents, yeah. And I actually, you parents would call and they would just tell you, I'll be there Sunday, because that's when her husband wasn't working and she could get the car or he could bring her. You saw it a lot.
so in the research, getting myself kind of up to speed because I didn't know anything about healthcare coming into this. A lot of the studies that I read talked about, well, two things. How parents of NICU babies oftentimes suffer from PTSD because they are, they almost lose their baby and sometimes almost lose mom in the process, that they have a slower transition to parenthood because they don't get to hold their babies immediately and do all of those types of things. And every study that I've read says that babies whose parents can either room in with them or be close by every day have shorter length of stays and better outcomes, and the family as a whole does better. What's your take on that?
There is no doubt. I mean, that study has been proven time and time again. And when, when you have so many families that may see their baby. And if people think this doesn't happen, it absolutely happens. That the whole time that their NICU baby's in there, they maybe see them, 3 or 4 times. And sometimes it's not because they don't want to, it's because they can't. They don't have the transportation or, so it happens.
So my takeaway from this before we wrap things up is that um, we have seen a relationship between two of the top three healthcare employers in this region that um, that gives providers and staff a very difficult time being able to speak out, being able to advocate for themselves and their patients, even where two companies that are supposed to be competitors seem to actually be more like partners to the degree where one can have the other impact their employees and their jobs and their positions. Where the concerns that were talked about early on with regards to volume and patient assignments. So it's not just the babies, it's the overall. It seems like the only people who have benefited from this merger and from the changes Ballad Health has made has been Ballad Health's bottom line, because it sounds like the staff and the patients and their families, in this case NICU babies and their families, have been hurt by these changes.
That would be my opinion because with the merger, and another thing that the merger did, it took out.
You're a little muffled.
Another thing that the merger did was it took out friendly competition and it took out friendly rivalry. And if you want to get better at something, if you want your tennis game if you want your tennis match, your tennis game to get better, play your rival. And there's just no there's just no rivalry anymore. You know, Johnson City and Holston Valley were rivals. We're better, they're better, and it made each other better. And it just doesn't exist anymore.
Yeah.
mean, this.
Go ahead.
It's not just the NICU. This isn't just the NICU. This is if you live in this area, this is your health care. This is my health care. This is what I have to live with now as I get older. My family lives in Big Stone Gap. They lost their golden hour with the trauma center closing. So, like I said, I wanted to come back to, you know, people that were angry with you, people that I heard were angry with you. They need to go on to, you know, and search for themselves. Let them learn how bad it really was and how they were sold out.
I appreciate you. You know that I love you dearly. And I've always thought that you were phenomenal in the way that you advocated for yourself and your patients. And you continue to advocate, even though you don't work here anymore, by speaking out for those people who can't speak out. And so that says a lot about your heart.
And I will continue to do so. I will continue to do so.
I know. I appreciate you. I know that everyone listening appreciates you. Before we wrap up, does anybody have, there's been a lot of comments on the side. I will take a question or two before we hop off of here. If anybody has a specific question that you would like to ask. I agree with you, Mike DeVoe. He says, awesome NNP always. Yes.
Yes. Love him. Come here, baby.
Yes, agreed, Martin Hensley. I'm going to give it just a second to see if any other comments pop up before we get off of here. I will say this, that my heart is appreciative because you know me, I'm never going to sell out the people who tell me things. I'm never going to reveal sources. I'm never going to say, I know this to be a fact because such and such and such and such. So for you to be able to verify the things that I've been saying for such a long time, I appreciate you. Every day that I look at Bella, I remember how phenomenal all of you are. And it hurts my heart that there are people not doing the things that they're amazing at, and that there are families not getting everything that they could be getting, because I got the best. And I know that that doesn't exist like it used to. So.
And when people put, you know, when they put their pocketbooks over, you know, and you can talk about standard of care. Who wants just standard? You know, let's strive for above standard. Let's strive for more.
Yeah. Our babies deserve more.
Absolutely.
The people of
our families deserve more.
Yes. Yeah, they do. All right. They're all saying thank you in the chat box. I know you can't see them right now. I love you, girl. I appreciate
it. And if any of my staffers are watching, you know, under the radar, you know, I love all of you all, and I know that you all try the best. But you all also know how I felt. So love you guys.
All right, you guys. I appreciate you all. Be amazing, be light, and be love. We're out of here. Peace.